Assalamu alaikum. Hello, everyone. Our meeting today is about ERA2024 latest clinical trials. Our distinguished speaker is Professor Mohamed Hani Hafez, and our moderator today will be Professor Yasser Abdel Hamid. Thank you all for attending our meeting. I hope you a fruitful presentation and fruitful discussion. Thank you. Please, Professor Yasser.
Thank you, Mu'tasim, our coordinator today, Dr. Mu'tasim Al-Sayed. Welcome, everyone, after our summer vacation in this new season of Egyptian Society and Transplantation CME chapter meetings, online meetings in the usual time and the usual Wednesday every week, 9 p.m. or 9:30 according to summer time. Today, I am pleasured and honored to have a great speaker, Professor Mohamed Hani Hafez, Emeritus Professor of Nephrology and Medicine, Cairo University. Professor Hani is the past president of Egyptian Society of Nephrology and Transplantation, and he is the current president of African Association of Nephrology and the current MISOT, Middle East Society of Organ Transplantation General Secretary. Professor Hani, when we speak about conferences, we should go to Professor Hani to summarize what happened in these conferences, what are the new data, what are the new trials, and what are the new to get in a capsulized form to summary for these conferences. And today we are in date with ERA24, which was done in Stockholm early this summer. And Professor Hani will summarize latest clinical trials in this conference, and will touch some other conferences, as he said to us, and we'll see in the presentation. I would like to welcome all professors attending with us. Professor Ayman Rifai, the president of Egyptian Society of Nephrology and Transplantation, Professor Hisham Al-Sayed, the president-elect of the society, and all other professors, and welcome all attendees, and welcome, and we're happy to see you and join this meeting. I will leave the floor to Professor Hani to run his lecture and come to you again after the discussion, which will be by the end of the lecture. So please, Professor Hani, start your lecture.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Professor Yasser. It is my great honor and privilege to be with you today. And I will try in around 3/4 of an hour to go around the latest clinical trials in nephrology. And I will be dividing my talk into actually 5 pieces. The first will address, the first part will be more clinical, addressing glomerular disease advances, clinical nephrology advances, dialysis and transplantation and advances. And the second part will deal more with advances in the basic sciences, including genetics, including histopathology, which are related, of course, to nephrology practice. Without much introduction, I will start by the glomerular disease. And as you know, IgA nephropathy has got many advances in the mechanism of its understanding in the late years. And there is a role of the complement alternative pathway and the terminal pathway and the lectin pathway, which led to development of different drugs for treatment. Also, there is a role for the inflammatory marker immunoinflammation, which gave a role for other drugs like sparsentan that we will discuss. And in addition, there is a role, of course, for the neficone targeting the gastrointestinal tract in a way. And in addition, of course, to rituximab, which is a maestro in most of the glomerular disease nowadays. Let's start with the sparsentan. And this sparsentan has got the project trial approved. After it has been approved by the FDA in September 23 in a dose of 400 milligrams per day. to be one of the new approved lines of treatment for IgA nephropathy. And this in this study, sparsentan is a combination of irbesartan and endothelin blocker together. And the follow-up was satisfactory with a marked difference in proteinuria at 36 weeks, 41% relative reduction in the proteinuria in the study. The second is the second drug, as I told you, will be budesonide, which is actually used by our friends in the gastroenterology since long time. But in this NefIgArd phase 3 study, it downregulated the production of IgA1 antibodies in the distal ileum. And in this follow-up for 2 years, phase 3 trial, 30% reduction in the eGFR from the baseline was in comparison to the standard of treatment. The third drug for IgA nephropathy, phase 2 trial of sibeprenlimab, which is a humanized IgG2 monoclonal antibodies that binds to and neutralizes APRIL, which is also involved in the pathogenesis of IgA nephropathy. And in this phase 2 multi-center study, 155 patients were included with intravenous doses at 2, 4, and 8 milligram per kg, or placebo once monthly for 12 months. Again, proteinuria reduction was 47% to 62% versus 20% in the placebo. So it was double or triple the placebo group. So expected that this trial will go to phase 3, and we'll hear in this INVENGEN trial good results in the coming years. The fourth drug for IgA nephropathy is iptacopan. And the study here is the APPLAUSE trial, which is a phase 3 multicentric study randomizing up to iptacopan 200 milligram twice per day versus placebo, and including 450 patients followed for 24 months. And the primary outcome was reduction of proteinuria and GFR slope. And there was, again, satisfactory result with the iptacopan. The next drug for IgA nephropathy is cemdisiran for patients with IgA nephropathy, which is actually acting on, as you see here in the cartoon, on the complement 5. It's subcutaneously administered, inhibits the hepatic production of complement 5, and is in development for the treatment of complement-mediated disease in general. And you see Dr. Jonathan Barrett, who came to visit Egypt previously, announcing the results for the phase 2 study of cemdisiran in adult patients with IgA nephropathy with very promising results again. Now let's move to the second glomerular disease, which is FSGS. And FSGS, as you know, has got a specific etiology in Africa and in African American related to APOL1, which led to development of inaxaplin. In addition, of course, there are so many causes for FSGS, including genetic weakness, hyperfiltration, obesity, all of these. And we know that RAS blocker has been one of the lines of treatment. But let's go and see what is the role of some new trials in FSGS. The first is actually the duplex study, which has been published in the New England Journal of Medicine, and studying the sparsentan again versus irbesartan in focal sclerosis. It's a phase 3 trial, including 371 patients, randomized to have 800 milligram. You remember in IgA, it was only 400 milligram versus irbesartan, 300 milligram per day, and follow up for 108 weeks. And the primary efficacy endpoint was the GFR slope in addition to reduction of proteinuria. Actually, there is some promising data, but it didn't got the FDA approval. So at 36-week, partial remission of proteinuria was 42% in sparsentan and 26% in irbesartan. So almost around less than the double. You remember in the other group, it was the 2 to 3 times. So it got the FDA very easily. But again, we are hoping that this will also make another breakthrough in the treatment of SGS. The third glomerular disease, which has got a real additions in the last ERA editor, was the C3 glomerulopathy and the immune complex MPGN. We have that, we know that eculizumab was tried based on complement etiologies of this, but the response is very low, only in 1/3 of the patient. But we have now some drugs like iptacopan, which has got another FDA approval on December 2023, and avacopan and danicopan. But there are also some promising data. This cartoon will show most of the complement inhibitor being investigated in patients with T3. You see here all of them in the left side: avacopan, iptacopan, pegcetacoplan, and please concentrate on this one because I think this will be the coming black horse, which has got, as you see on the discovery study, Nobel study, Valiant study, and Valley study, most in phase 2 and phase 3, and I expect that this will be the winner soon, because as has been presented by Dr. Erika Daina in the ERA editor, this discovery study led to a clinically meaningful reduction in proteinuria at week 48. And in the Nobel study, it was associated with a reduction in proteinuria up to week 12. This is the detail of the discovery study. No serious side effects were observed, no meningitis or sepsis cases reported, and a majority of side effects were considered unrelated to the study group. In the Nobel study, it led to a reduction in the activity score up to week 12. What was very promising here, that additionally, there was 70% reduction in the activity score in the group versus 30% in the other group. Additionally, it increased, the C3 increased and the plasma C5b9 was normalized. So I think this drug, pegcetacoplan, will be coming. This is a third study on it. It's called the Valiant study, evaluated its safety and efficacy in patients with C3 glomerulopathy and primary MPGN. And again, the results, the primary endpoint and the secondary endpoint were satisfactory up till now. It has been investigated in, as you see, in at least 3 studies. The fourth glomerular disease with some improvement is the membranous nephropathy. And as you know, membranous nephropathy since long time, we are accusing the PLAR, but it is not present in all cases. It is present only in 60 to 65% of the cases. And there has been new target antigen detected by mass spectrometry, as you see here in this presentation by Dr. Gemma Maria from Spain. You see many antigens accused, but actually the Mayo Clinic group chose from these many antigens 14. They selected 14 of them, and they found that some of them are very pertinent and important, like the NEL1, for example, in 10% of malignancy associated, and the TGF3 beta and the thrombospondin. And therefore, the future will be some drugs which are targeting these specific things. This is, again, some of the new drugs or the new option for treatment of membranous GN, including anti-CD38 like daratumumab and felzartamab, anti-BLyS, which is belimumab, that we will come to it soon when we are speaking about lupus, anti-complement therapy like the iptacopan that I just mentioned, proteasome inhibitor, the bortezomib or the Velcade that we are using in multiple myeloma and similar diseases, and the anti-CD20 obinutuzumab also in our practice. But I think the advance here is more in daratumumab and felzartamab. What about the emerging therapies for lupus nephritis? I will just tackle 4 advances. One of them is the second generation of rituximab, which is obinutuzumab in the Nobility trial, which got, again, good results. The second drug is the safnilo or the anifrolumab, which is a type 1 interferon receptor antagonist that is used in cases of lupus nephritis, and still according to the TULIP study in phase 3 trial and the MUSE trial in phase 2 trial, it is given by injection, and the side effects are some bronchitis and infusion reaction and herpes zoster. But I think this will be also intravenous used 300 milligram per vial, and it could appear in the near future. But what is available more or less nowadays is the voclosporin, approved by the FDA after 1 year of trial, and the belimumab after 2 years also. All these 2 drugs are now available for the cases of resistant lupus. By this, we finished the first part, which is the advances in the treatment of glomerular diseases. What are the advances in clinical nephrology? Are there any ways to use other drugs to delay the progression of chronic kidney disease, for example? Yes, we will start by the aldosterone antagonist. And aldosterone synthase inhibition with or without background sodium glucose co-transporter has been addressed in this study presented in the American Society of Nephrology, combining the 2 together and having an additive effect if you add the SGL2 to the aldosterone synthase inhibitor, a promising therapy that may add benefit whether the patient has diabetes or without type 2 diabetes. And it reduced, as you see in the conclusion, this combination reduced the albuminuria by up to 40% in participants with CKD. So this is a significant improvement in this study. This is another study of aldosterone antagonist, but actually it was rather a negative study because they tried to use, by the French group, this aldosterone antagonist in chronic hemodialysis patients and see if they have any survival benefits when they are given to the patients on hemodialysis. Professor Ziad Massi, who also came to Egypt before, was one of the investigators. And in this Alchemist study, no improvement in primary cardiac criteria, only some decrease in the hospitalization, but it was not very promising. But the second weapon that I will say that now the nephrologists are using some new pillars, like what the cardiology say. We have many pillars in the treatment. So the nephrologists nowadays will start to use pillars. And the first pillar, as I mentioned, will be the SGL2, and the second pillar will be the aldosterone antagonist, the new one. And the third pillar here will be the GLP-1 receptor agonist. And this study was the award trial showing the effect of GLP-1 receptor agonist dulaglutide on the profile of circulating miRNA associated with end stage in type 2 diabetes. And it could, in this study, it showed a preliminary good result. But what was really a big advance is the FLOW study. The FLOW study has been presented very well in Stockholm. And as you see, they screened around more than 5,000 patients, and they ended by around 3,500 patients divided into two similar arms, each of them around 1,700, and a very minimal number did not complete the study to the end. Here, around 400 in each group, and the trial design was to randomize them to either to take one injection of semaglutide subcutaneous plus the standard of care, or and the other group will not take. And they are following all the parameters, especially the GFR, the proteinuria, etc. And you will be astonished by that they included very bad patients in this study. They took patients who have 93% risk of CKD progression. 42% of them had comorbidity burden in the form of prior MI or stroke or chronic heart failure. So they choose the worst patient. And in spite of this, also 15% of the patients were on SGLT2 inhibitors. So they were not very well protected. And in spite of this bad selection and these bad patients and the very minimal use of SGLT2, they got very promising results, whether in the primary outcome for kidney or the secondary outcome, including the time of occurrence of all-cause deaths, cardiovascular deaths, and other supportive secondary outcomes. And you see here the data in detail. The estimated treatment difference, this is very important. When you see how the GFR calculated by cystatin C in the group who took the semaglutide versus in the group who took the placebo. After this number of days, time since randomization in weeks, sorry, after 156 weeks, you see the difference, estimated difference is at week 104 is around 3.3 milliliter per minute, which is very significant in the long term in delaying the progression of kidney disease. Not only this, but the albumin creatinine ratio also, urinary albumin excretion in the semaglutide was here less proteinuria versus the placebo. And the composite, when we add all of them together, the composite endpoint for the kidney, all of them were in the favor of semaglutide group. Here the difference was not very marked, placebo 23.2 versus semaglutide 18.7. But if we take all the results together, we find that there is 24% lower risk of the composite primary outcome, consistent risk reduction for kidney disease, consistent risk reduction across pre-specified participant subgroups, slower reduction of the kidney function. As I told you, the GFR will be decreasing in a less way. And over 3 years, 20 people would, the number needed to treat is very small. You need to treat only 20 people to prevent one primary outcome. And as you know, the lower the number, the higher the benefit of any drug if the number to treat is small. But there is another weapon that I mentioned, but I can give you another study about it, which is the sotagliflozin, because you know there are so many gliflozins nowadays in our practice, but this is again a newcomer, which is expected in the SCORED trial to finish the study. It will include 2,302 non-dialysis patients and follow them intervention they started in the 3rd of November 2023, and expected that again the cardiorenal outcome will be important. You remember with me an old drug called bardoxolone, and this bardoxolone actually was bardoxolone was withdrawn from the market long ago because of claims of cardiac mortality and increase. Therefore, the Japanese did not continue its production. But this is another, again, study coming from Japan called the IAMI study, which randomized a double-blind placebo-controlled phase 3 study of bardoxolone in diabetic kidney disease. And what they found in their result, that the follow-up here, look to this, the placebo versus the bardoxolone group. There is no increase in the cardiac side effects. And in the same time, the primary endpoint, which is decrease in the GFR, was 30% decrease. And the secondary endpoint, again, was clear. So they are claiming that this drug could be used in diabetic kidney disease. But I think we need another confirmatory study coming from a place rather than other than Japan. Here there was some warning about the use of antiemetic ondansetron or Zofran that we are using very much, because it could be associated with some QT prolongation. But the number of cases is not very significant. Yani, the risk is not very high to justify the stopping of use, but you should put it in the list of the drugs that are associated with long QT study. Now let's go to dialysis. In 2021, this paper came about the high volume HDF, the future standard of care in chronic dialysis. Could it be the future or not? But very rapidly, in 2023, June 2023, the New England Journal of Medicine are publishing the CONVINCE trial. And the CONVINCE trial showed a very good result in the group. You see, each group is around 1,400 patients almost. And the overall survival was higher for the high dose diafiltration versus the high flux hemodialysis. And therefore, it could be important, especially in if we select some patients that are in need after many complications and after long-term complication to this form of treatment. You see here that the value will be more in some groups of patients here, like maybe the elderly, and if there is associated cardiovascular or diabetes, also the data will be more promising also. What about the criteria, for knowing that if our dialysis patients will have a prediction of mortality or not? And this was the measurement of the long pentraxine role. And it was found it is a predictor of mortality in dialysis patients. Because if we measure it, in addition, of course, to the albumin and all the other parameters, it could be an indication that those patients have a sort of inflammation that should be reduced. The glycated albumin may help also predict end-stage renal disease, cardiovascular event, and mortality in CKD patients, according to this study. The genetics could be used in peritoneal dialysis to segregate those patients who are, for example, having the genotype TT versus CC. TT is the worst in prognosis, and they have high rate of technique failure resulting in transfer to hemodialysis. So some genetic study for those patients who do not respond to peritoneal dialysis may help to know which patient will have the aquaporin 1 genotype. These are the aquaporin genotype, which is responsible TT or CT or CC, or a combination which is CT. Now, what about the best fluid to be used after transplantation? And there is evidence that the saline that we are using may not be the safest fluid to use due to its high chloride content. And according to this study, using a solution with less chloride and less sodium will be beneficial. And this has been called the better evidence for selecting transplant fluid or the best fluid. And you see here that the serum creatinine at day 7 is better and the urine output is better. So there is also, again, a number to treat which is not very high, only 10 patients to prevent 1 case of delayed graft function. So there is an advice to use this in the future. What about some tegoprubart, which is has been studied in a group of patients having a kidney transplantation from some Canadian group, giving 20 milligram per kg intravenous administered every 3 weeks after initial loading, in addition to mycophenolate and corticosteroid. The number, of course, was around 5 to 6 patients, which is not a big number, but this is a new group that may have in the future because it works by on the CD40 ligand, which is one of the important mediator of inflammation. IDIS has been studied for a long time, IgG endopeptidase in highly sensitized patients undergoing transplantation. And the problem with IDIS, all of us were a little bit afraid because if we inactivate the complement as the antibody, we are afraid that after some time after the transplantation, there will be more antibodies coming to, if the cross match will be negative, again, it will be rejection after that. But in this follow-up by the French group, they are giving 4 to 6 hours after imlifidase infusion and following the patient for a long time. And their result here in this French study was very promising. They give also ATG and they give also mycophenolate mofetil. And this is their protocol, as you see here. And the result is graft survival at 3 years, follow-up of 3 years, was very promising with acute rejection, not significantly different from those who didn't take this imlifidase. Again, this important study was about the induction. We know that what we use in general for induction is the ATG, antithymocyte globulin. But there was some comparison with alumtuzimab to see if this alumtuzimab would be higher or better in the long run. And this was a big number of patient studies and compared with each other. The result is seen here, and the conclusion: kidney transplant with alumtuzimab had a significantly increased risk of rejection, leukopenia, transplant failure, CMV infection, and BK virus nephropathy. So it seems that it is more wise to go as we are doing with ATG. Again, about the delayed graft function with calcineurin inhibitors, and we see here that delayed graft function, the patient mortality in the BILA group, in the belatacept group, compared to the classic use of in the Symphony protocol, which uses tacrolimus, the side effects of and delayed graft function was higher in the belatacept group in a big study carried by Yunus. So it seems that also we don't need much belatacept as long as our classic protocol are good. This Yunus data was done on a very big number of patients between 2010 to 2022. And these are the results reassuring us about the data. You see the number here, 194,000 plus patients on tacrolimus versus 5,000 plus on belatacept, and the data were in favor of the tacrolimus versus belatacept. This is recurrent focal segmental sclerosis following renal transplantation. And here we see the presence of circulating nephrin autoantibody at the time of transplant was associated with post-transplant early recurrence. So it could be one of the follow-up studies that we measure the nephrin if we want to do another transplantation for a recurrent case. What about in this Admiral study? There is, of course, much notion nowadays about the cell-free DNA of the donor, which is present in the patient in the transplant recipient blood. And this Admiral study gives an indication that this could be very helpful, and it has been followed for around 3 years of outcome surveillance analysis, and see if there is I could not say a substitution from the biopsy, but at least an indication that this could be a way to know what will be the prognosis. Therefore, there is now more and more studies in this direction. This another study report a DNA more than 0.58 suggestive of ABMR, which in the future can be used as the only non-invasive test to diagnose ABMR. And this pushed some investigator to do what we call the EU train study, including 8 European transplant referral center and 11 United States center. And this study is still ongoing, and these are the center included in the study. And I think after the results will be published, this line of investigation will be one of the bases of treatment of transplantation. Torc-tinovirus is a potential surrogate parameter to monitor the degree of immunocompetence in a kidney transplant early after transplantation. And in this post hoc analysis, we see if there is a correlation with rejection, with infection. And actually, it is also, again, one of the important ways to know if there is ongoing infection. Another test is the by the French group is the multidimensional prognosis by the mortality M-box. This actually has been published in the American Transplant Congress around 2 years ago by the group from France, and they enrolled more than 1,400 patients, and they selected 19 predictors to know if the patient will get follow-up after 10 years mortality, and if the patient will die after a median post-transplant follow-up time of 7.6 years. And the parameters were, some of them were clinical parameters, like age, history of cancer, diabetes, chronic obstructive pulmonary disease, cardiovascular event. Some of them were investigation, like HbA1c, C-reactive protein, albumin, gamma-GT, uric acid, etc. And the mortality score showed accurate calibration and discrimination at 10 years follow-up. But what happened is that this study, published 2 years ago, has got wider percussion in different journal, as you see here in the BMG, in the Lancet, the KDIGO, American Society of Transplantation, etc., by the same group, by Alexander Lupi and his French associates, giving us more hope that this study will be more and more international. And that's this is the situation nowadays, because in the last era in Stockholm, Lupi mentioned that application of this iBox in clinical trial is still ongoing, and now they are making a prospective randomized control trial to assess its use, a clinical decision support system to follow the kidney transplant patients, and including 507 subjects in multi-center, and see the end of the follow-up will be by November 2024. And when we know this, we will give you the data about it. Is there a value of artificial intelligence in the transplant community? Yes. We have, by artificial intelligence, got many data about the comprehensive transplant cohort and the prospective kidney transplant cohort, the biomarkers and immunology, allograft phenotyping, and you see here all the publications in different journals, molecular technology, and data science bioinformatics. We are aware that antibody-mediated rejection are not the same. We have some of them with active antibody-mediated rejection, and maybe these are the easiest to treat, but the chronic antibody-mediated rejection is usually more difficult to manage. The subclinical rejection, there is a debate to treat or not to treat, but is still also possible to manage. And the line of management that has been presented by Carmen Lefoucher from Paris are of these types of antibody-mediated rejection include, of course, IVIG, rituximab, obinutuzumab, acting on anti-CD20, ATG, cyclophosphamide, bortezomib, tocilizumab, interleukin-6 inhibitor, IgG endopeptidase, eculizumab, and C1 esterase inhibitor. All of this has been used. Now let's go to, in this way, I finished the first part, which is the most important, which is the more clinical advances in nephrology. Let's go now to some basic advances, including, I will address actually some of them, which are the RNA as a drug, the serans, piezo's, what is piezo 2 and piezo 1, the sex difference in the immune system, the histopathology of nephrology improvement, and the genetics and the regenerative medicine. And let's go a little bit rapidly by the first item, which is the serans. How it works, this small interesting small RNA, small interference RNA, now invading the different vaccines like the COVID vaccine, for example, and invading the different FDA-approved drugs for the treatment of hyperoxaluria, like, for example, the approved, as you know, in patisiran, lumisiran, etc. What is the piezo's? The piezo's is actually a sort of touch receptor. And they found that these touch receptors are present in the kidney itself. They are expressed in the juxtaglomerular apparatus and the glomerular mesangial cells in mice, and probably also in humans. And they have got a role very important in the RAS system. So they are telling that the RAS system should include also this piezo, mechanically activated ion channels. And maybe in the future, we will have drugs addressing piezo 2 and piezo 1. Piezo 1 will be also very important in the management of anemia in the future, because they found that the cases of osmotic fragility of the red blood cells, especially in uremics, in renal anemia, is dependent on a piezo 1 pathway. Understanding this molecular mechanism can help developing new therapeutic approaches for renal anemia in the future, addressing this piezo 1 pathway. The piezo 2 is essential for regulation of the RAS system, as I told you, and it could work before the juxtaglomerular cells and before renin, and elevated renin has downstream effect on the blood pressure. And you see here that piezo in renin expressing cell regulates the plasma renin by acting as a brake on the RAS activation. Is there a difference between the immune system of men and women? Of course, we are in the era of women in nephrology, and therefore, yes, we should know that innate immunity is different a little bit between men and women. Women are more prone to autoimmune disease and inflammatory disease. You have the example of lupus, for example, due to increase of dendritic cells, interferon gamma production, macrophage activity, etc., and the adaptive immunity mechanism, while men lack these things, and maybe they are more prone to other types of disease, like, for example, the Parkinson disease, which is more common, and more neurological affection. Again, also the hypertension, for example, is more common in men, especially before, if we compare before menopause, because they found that there are some olfactory receptors. They are localized in the afferent and efferent arteriole, explaining the sex difference in blood pressure, or why young women don't have hypertension like young men of the same age. What is the mechanism of progression of renal fibrosis? Gradual progression of renal fibrosis ending into the loss of the grafts. For example, 50% of the grafts are lost after 10 years because there is C4D T cell increase with age, and age-associated B cells also increase with age, and these are promote the formation of tertiary lymphoid tissue and lead at the end to fibrosis. And this raised the idea that there is a possible role for antifibrotic in the management of late transplant cases, especially chronic rejection that I told you are not easy to treat. So there is some claims that some drugs like, for example, perfenidone, which is used more with the pulmonary fibrosis, could be used in delaying the progression of fibrosis in our patients. What about the advances in pathology? Here, this presentation in the ERA editor from Netherlands, speaking about the digital pathology computer vision and how will be the future of biopsy. Because as you know, in the biopsy, we are only taking a small part of the kidney, but they are telling, no, we need to know more holistic approach of the kidney. So they are speaking about what we call segmentation. The basis of quantitative pathology is going into multi-label instance segmentation, which gives you different color for the different components of the kidney, as you see, the interstitium, the glomeruli, etc. And this is an example of what we may see in multi-class, multi-label segmentation picture, as you see in this paper published in 2023. A machine learning driven virtual biopsy system for kidney transplantation will be one of the things to be waited for in the future. The super resolution microscopy, which is actually a new light microscopy technique that overcomes the physical limitation and even is very simple. You see here the nice picture of podocin, synaptopodin, etc. by this technique. And this same technique could be seen in multiple publications, as you see here. The super resolution microscopy enables easy multiplex staining in high resolution for biomarkers, new biomarkers, messenger RNA quantification, GBM measurement, endothelial and mesenchymal cell evaluation. So there is much to await from our pathologists in the future, whether by digital microscopy, by whole evaluation of the kidney by these ways. Again, what is the value of genetics? Genetics in transplantation. Genetics here is very important, especially if we are dealing of the diseases of unknown etiology, because exome sequencing provides diagnostic yield in around 10% in patients with chronic disease, especially those with unexplained CKD. This is an example of diseases that could be amenable to treatment if you know their genetics. For example, Liddle syndrome can be treated by amyloid. Hyperaldosteronism could be treated by thiazide diuretics. Fabry's disease by alpha-galactosidase enzyme replacement. Primary hyperoxaluria, as I told you, by the RNA therapy. APOL1 associated kidney disease by the new drugs coming for APOL1. So knowing the genetics could help to tailor a specific therapy for each of them. And especially if you are going to transplant a patient less than 50 years, expect that it's better to know the genetic, otherwise you will have a problem and you will be confronted by some syndromic disease or some recurrence of rejection after a short time from the transplantation. Again, you can expect the risk of cardiometabolic, even the cancer risk, by knowing some genetic parameters. So the risk of cardiometabolic disease is increased, for example, with LDL receptor familial hypercholesterolemia. The risk of cancer by some genetic marker here, like BRCA1 or MSH2, increasing in colorectal cancer. The risk of infection is increased if you have this marker, and the risk of thrombotic complication if you have factor V laden. All of us, we are aware about this protein C, protein S, factor V laden, etc. So the risk of thrombotic complication also for vascular procedure during transplantation could be increased. So not only vascular complication, but the risk of cancer, infection, cardiometabolic disease could be addressed if you know the genetics well. Are we in the era of having human kidney organoids for disease modeling and regeneration? Yes, we are. They are speaking since long time about stem cell genes added to adult cells and reprogramming them to create a 100% immunocompatible organ that needs to be transplanted without giving immunosuppression. This will help us, of course, in all the pharmaceutical study, but it's still away from being applied as a substitute from the human kidney. What about the xenotransplantation? Of course, we cannot leave these advances without speaking about the University of Alabama and their success in the pig to human heart xenograft and also in the kidney xenograft. But they were confronted by a porcine cytomegalovirus, latent virus, which led that the patient also survived his heart, but he died from a CMV coming from the pig. So it is very important in these studies of xenotransplantation to be careful from the zoonoses and the delayed immune response. We still have much to do in the future about that. The last thing, the last part that I will discuss was a very important preliminary presenting how fasting may help to prolong life. Of course, this presentation was one of the key master of the ERA-EDITA. Progressive aging in these mice was associated with putting them on fasting. What happened is concomitant with lifespan extension. Dietary restriction delays aging in all organs, tissues examined, the liver by different mechanisms like anisokaryosis and polyfluidization decreasing, the kidney, tubulonephroses and anisokaryosis are decreased, the immune system, T helper subpopulation and the IgE level, in the retina, in the vascular system, in the neural system, and therefore the conclusion of this gentleman, of this scientist, is that fasting will be, intermittent fasting will be one of the lines that may help you to survive more. These are some picture of what happened in ERA-EDITA, and I will finish by this algorithm will not replace doctors. Advances that you have heard will not replace doctors if you follow them. However, doctors who don't use algorithm and advances will replace those who don't. Thank you for your attention.
Thank you, Professor Hani, for this very illustrative, interesting journey through ERA-EDITA and some other conferences 24, and giving us the latest informations in all fields of nephrology. As in glomerular diseases, you started, of course, by the IgA, which is our start today, and its coming stars sparsentan, also FSGS and the role of sparsentan, FSGS, new markers for diagnosis of membranous nephropathy. Of course, membranous is taking a long part through its diagnosis, which marker and the appearance of new markers other than anti-PLAR-A2 is of hope nowadays. These were in the GN and coming through the clinical nephrology and the common drugs, you address new drugs of the common groups we use, such as aldosterone and aldosterone antagonists and SGLT2 inhibitors, and also the flow study, which proved the role in GLP-1 agonist in kidney protection, and its marvelous study results. Coming to dialysis, HDF, which is the common use nowadays, high volume HDF, and again focusing on CONVINCE trials and its results. And I think Professor Hisham will not let you for this point, and will criticize this CONVINCE and say that the criticism we all know about the CONVINCE trial. And of course, PD, the new PD and markers for PD for diagnosis, and your point of interest and your point of heart really is transplantation. You took a great part of this talk. Which fluid to use in post-transplantation care, which is important point here. I can see that you stressed that it's balanced crystalloid, it's not simply the saline. And coming and you give us back to the our usual protocols. No role for platacept received or altuzumab in transplantation, and we are to stick to our usual protocols of using tacrolimus, also recurrent SGS and nephrins, and the role of cell-free DNA in Admiral study in diagnosing and, or, as you said, monitoring of rejection. iBox or inbox in prediction of survival is coming, and I think, as you said, will take place, and we hope that by the next year we can find more role for it, role of artificial intelligence, and really the part of the basic science, which was in the last of this talk. It was very interesting and giving us informations, PISO 1 and 2, and anemia, and treating osmotic fragility, and the role we may have new drugs in targeting anemia, gender differences, and the role of fasting. You addressed even the role of fasting in prolonging health. Thank you so much for this very important journey, Professor Hani. And you have some questions in the chat. Of course, we have questions in the chat, and we have many comments. So please, Professor Ayman Rifai, the president of Egyptian Society, the current president to the past president, questions. Please, Professor Ayman.
Thank you, Professor Yasser. Thank you very much, Professor Hani. You are always entertain us by presenting the updates and everything new that have been presented in the international nephrology meetings, and actually in a very interesting and enjoyable way. Thank you, Professor Hani. Of course, you raised a lot of interesting points that needs hours to discuss, but I will select just 3 points to discuss. First, for the IgA nephropathy, you mentioned a lot of drug and therapeutic agents, but I think currently there is an evolving rule of the anti-complement 5, which is the replacing now the eculizumab, which is ravulizumab, and which is now manufactured by AstraZeneca. And there is some recent trials that there is 40% reduction in proteinuria in patients receiving ravulizumab. It's currently available in the Egyptian market, and AstraZeneca is trying to perform a multi-center trial for treating IgA with ravulizumab, and they asked it to participate in the trial. There is any data about the ravulizumab in treating IgA nephropathy in the ERA data, in the last ERA data?
Actually, no. There were no data, no recent data. They were concentrating more on the groups that I mentioned, Sparsentan, which is got an FDA, and budesonide. Of course, the eculizumab, did not give a very good results in the initial data, and therefore they are maybe they think that ravulizumab, which is very near to its the same mechanism of eculizumab, would not give a very high. That's why I don't think there were important presentation about that. If maybe it was an industrial presentation, but I didn't attend it yet. I'm not sure.
Okay. For transplantation, you mentioned that there was a comparison between the induction therapy between ETG and alemtuzumab.
Yes,
and
yes, this was very important.
Yeah, and you mentioned that with alemtuzumab there was a lot of infections, CMV, and so on. But I think the key is not to get these bad side effects, that we should implement a minimized immunosuppressive protocols after giving alemtuzumab. I mean, we are not going to give the standard of care triple tacrolimus-based protocol after giving alemtuzumab. When we have our trial in Mansoura between 2005 and 2008, and we included 61 patients in this trial, we used a minimized protocol. By minimized protocol, I mean steroid-free and CNI-free. And we didn't get these side effects with the minimized protocols. We have 85% of those patients with steroid-free, and 75% were steroid-free and CNI-free. Most of these patients were kept just on mTOR inhibitor, sirolimus plus or minus antiproliferative like azathioprine or small dose of MMF. With these minimized protocols, we didn't find this side effects actually. So I think alemtuzumab, which is currently given in UK, for example, as a single dose, subcutaneous, intraoperative, or just before the surgery, and they are it's doing well. The problem that is not available in Egypt anymore. Otherwise, I think this is the best and the cheapest protocol also for transplantation without these side effects. What do you think?
I think yes, with this comparison, of course, it's taking a big number of patients, all over, as I told you, over more than 10 years. Definitely a good selection of the patients and giving less strong immunosuppression after giving the drug will reduce the incidence of infections. And of course, maybe at that time, the mTOR inhibitors were not very licensed in the United States to be used on wide base. I think since long time, the protocol in the United States is depending on tacrolimus, mainly.
Yes.
Even before Europe, you remember Europe in the old days, it was more cyclosporin, while United States since long time is giving tacrolimus. So probably, as you mentioned, the data that they are publishing is tacrolimus dependent. I mean, those patients took tacrolimus after that, and this may explain their bad outcome. This is one point. The second point is the problem with alemtuzumab is that sometimes when there is a rejection with alemtuzumab, the number of memory cells that are present in the circulation is high, and usually the rejection is a little bit resistant to treatment. I mean, because of the presence of high memory cells. So if it passes smoothly, it will be very good. But if there is a rejection, I don't know in your series if you got some of them rejecting. If they got a rejection, it will be a little bit difficult to treat. This is my impression about.
Yes, completely right. There is what is called escape phenomena, because some plasma cells are. This is a rejection with rich plasma cells, and plasma cells is escaped from the effect of the alemtuzumab, and this is a resilient rejection. Yes, you are totally right. Last point to leave the chance for our guests, about the recurrent focal segmental. You mentioned that we were always searching for several permeability factors, but you mentioned the nephrin. So these studies advise to measure the circulating nephrin for a patient who is going to be transplanted.
Retransplanted,
And
yes.
the first transplant was failed due to recurrent focal segmental.
Yes.
So
yes.
So it's just the nephrin.
Of course, you remember that there have been so many agents in the past claimed to be measured and to avoid recurrence. But this is a recent marker. I don't know if it is alone will be enough, or we need to have other markers to be with it also.
Thank you very much, Professor Hani. I really enjoyed your talk. Thank you.
Thank you, Professor Ayman and Professor Hani, for responding to the question. I have a question, Professor Hani. You said that there is no, in dialysis patient, there was no observed effect for aldosterone antagonists for treatment of heart failure.
Alchemist study اللي هي معمولة in France. Yes, Alchemist.
Is there any explanation, as we all know that the aldosterone, finerenone, and something like this all have a good effect on cardiac lesions?
I think because the bad selection of the dialysis patient, in which the atherosclerotic disease is not only dependent on like in the normal population, there is an element of CKD-MBD and deposition of calcium phosphate. Calcification بالضبط. يعني CKD-MBD will be one of the factor before the cardiac death. So if you correct the by SGL2, it will not be 100% corrected, except if you reverse these how pathological phenomena which took time.
Different pathogenesis, specific type of pathogenesis.
It is expected that these cardiac factors in those dialysis patients is multifactorial. So just giving SGL2 will not solve the story. Sorry, just giving aldosterone antagonist will not give protection.
Okay, thank you. Professor Hisham Al-Sayyi, please.
Thank you very much, Professor Hani. As usual, 1 hour all over the world in this journey. We are waiting every year. I have just a few comments and questions. I will start from the last point of aldosterone antagonist. It depends on the bulk effect of the aldosterone antagonist. Is it primary, cardiac, or renal? For example, it differs between eplerenone and finerenone on the selectivity more for the renal. I think we have to define that.
Finerenone is better, much better, of course.
Yes. What is the drug?
Both in renal and the cardiac, Professor Hisham.
Yes. Yes, but mainly on the renal, depending on the mechanism of aldosterone difference between eplerenone and finerenone. What is important for aldosterone antagonist is the blocking of the big potassium channels, calcium dependent in the colon, which is upregulated in CKD and on dialysis patient for excretion of potassium. So there is a tendency toward aldosterone agonist for excretion of potassium from the colon in patients with CKD. So this may have some antagonistic effect for patient on dialysis. Considering pentraxine, this year I just finalized one of the biomarker in hemodiafiltration is pentraxine. And thank you for highlighting that. It's a big molecule and removed effectively in hemodiafiltration and has a very correlation with the endothelial cell damage. So pentraxine could be one of the promising biomarkers for survival. Considering CONVINCE, I fully agree that, and recently published 1 month ago in Kidney International that sub-analysis patient in CONVINCE has improved quality of life for sub-analysis of the CONVINCE. My question now, you mentioned perfectly cell-free DNA, which is many types, neuronal, mitochondrial, and other, and it's correlated in many diseases, including dialysis and antibody-mediated rejection. But at this moment, it's a good biomarker, but will not be available at ease. But it's related to morbidity in dialysis, in renal transplantation, predictors, in cerebrovascular accident as well. But what do you think? That is it just a biomarker for publication or could be a laboratory work?
I think with the recent trials that are trying to make, they are trying to popularize it as a way before biopsy. I mean, as whenever you start, before, of course, the rise of creatinine. I mean, to give you an idea if this patient is going to reject or not, before you need, especially if they prove that there is a window or a time factor between the rise of this marker and the rise of creatinine or cystatin. So if they prove this, it will be very helpful. If
Yes,
it is, for example, 10 days before or 2 weeks before the rise, it will be very, very helpful in the future, even better than protocol biopsy.
Yes, it's a very for many diseases. My last comment for you is subhanallah, we attended together the plenary session of fasting and the effect of aging and the effect even in renal transplantation outcome. So not to just say subhanallah.
This is one of the secrets of the value of Ramadan fasting and of intermittent fasting in different occasions, that even this scientist proved that this is very helpful to lengthen his life according to the life.
Yes, exactly. Thank you very much, Professor Hani.
Thank you, Professor Hisham and Professor Hani. We have some questions from our dear friends in the chat. Dr. Abdelhamid Hamdi asking about membranous with the sky high anti-PLAR-A2 receptor antibody level. Does plasma exchange help? And in such cases, rituximab or cyclophosphamide is preferred?
There is no much data about plasmapheresis in membranous, but rituximab, yes. Rituximab is effective, could be effective, especially in recurrence of membranous after kidney transplantation. It is effective, and I think if you have a very high level, yes, rituximab, and with high proteinuria, it could be one of the good line of management.
He is asking another important question, really, about semaglutide with its known mechanism of action, regulating gastric emptying, increasing gastric empty. What is the effect on immunosuppressive drug therapy in drug level, in kidney transplantation? Is there any effect, known effect, or still not studied, or no effect?
You mean a patient who got transplantation and you will take semaglutide?
Yes, GLP-1.
Yeah. I'm not sure, of course, about the drug interaction with them. I think we should go and revise it. If there is interaction with tacrolimus, for example, or with mycophenolate, I'm not aware yet.
Okay. Question from Dr.
But
Ala.
it is advisable. It's advisable, of course, to try to keep the transplanted patient as slim as possible, because the problem is that when they start from the frailty or cachexia of dialysis and start to eat, they very easily may become obese, and the steroid will help them also to increase. So it is very important to keep their BMI not very high, and maybe semaglutide or others drugs helping that they don't become obese will be one of the line of management. But of course, we need to be sure that they don't interfere with the immunosuppressant.
For my knowledge, say that we give similar drugs, DPP-4 inhibitors, acting nearly same mechanism in transplantation. Yeah. There is no effect and no recommended change in the doses or extra monitoring, which has similar. Another important question from Dr. Ala. He's asking solutions, Hartmann solution with low chloride, very low chloride, or saline. And I think you said it clearly, balanced solutions are preferred than saline.
Yes. Actually, it was one of the solutions. The best fluids study was done with one of the companies, I think Baxter, producing a ready-made solution which is low in chloride and low in saline. This is it was their solution, but of course, any solution which is low in chloride and in sodium will give the same result.
they designed a specific solution.
لكن هي كانت study معمولة على study على الفلويد marketed by Baxter.
Okay. Last questions from Dr. Abdelhamid and Dr. Ala is speaking about HDF, and I think we clarified this point. Dr. Abdelhamid asked about ingreen nephrology, role of ingreen nephrology. Of course, he is speaking about the high volume elaborated during this part of treatment, and I think Dr. Saeed Khamis addressed this point clearly in a very comprehensive lecture in the last, I think, was in May or April. And he can find it clearly on our YouTube channel. And the last question is about HDF. If the patient feels well, asking simple question, does the patient feel well with HDF? He speaks about ask about quality of life with HDF.
I think in this study, which the study of in Convince, there were more than one company, more than one academia, more than one hospital. So definitely the well-being of the patient was addressed by different criteria. For example, there are multiple criteria to evaluate if the patient is happy or is satisfied by the quality of life given. And there was no negative input at all that the quality of life is becoming worse. The opposite. I think, for example, if we are speaking about a sort of peripheral neuropathy, or restless leg syndrome, or anything coming from the long-term dialysis due to amyloidosis, all these chronic side effects are expected to improve with this modality. So, of course, they did not make a very follow-up of the quality of life because the results are very recent. They are just published a few months ago. But I think they will be in the coming, this could be done by us. I mean, compare the quality of life. And I think in the last week, I discussed with Ain Shams University one of the MD theses addressing exactly this question. Dr. Magdi Sharqawi and Dr. Hisham Sayed were the main investigator, and this study has been selected by the next American Society of Nephrology Congress to be presented as an abstract. So it was actually answering this specific question, and the data were very positive regarding the quality of life. It was better in this HDF group in comparison to the hemodialysis group. صح يا دكتور هشام اللي هي الرساله
لا دي تمام.
مش كده؟
طبعا better even Kidney International this month published the quality of life sub-analysis في الconvince وapprove better outcome for quality of life in hemodiafiltration group.
وفي الرساله بتاعت البنت اللي انا ناقشتها كان مش متذكر اسمها ايه
على ترانسبلانتيشن والهيمودايفلتريشن.
لا ايوه بالظبط، ما دي الرساله كان فيها كواليتي اوف لايف بتاعتكم كانت
better quality of life.
طبعا
اتفضل دكتور. اتفضل حضرتك، اتفضل يا دكتور يعني كمل.
لا انا بس مش متذكر اسم الكانديديت اللي انا عشتها. ميريهان ايوه اسمها ميريهان بالظبط. رساله ميريهان صح كده.
بتيت ميريهان دكتور.
ايوه
which is logic ان ال HDF يكون ليه better quality of life and we waiting for the results documented
هو
results.
طبعا دلوقتي بقى في انت عارف السونج كرايتيريا اللي هو كل شويه evaluate البيشنت perception of the management، فغالبا هيطلع سونج كرايتيريا تقول لك بعد شويه ان ال HDF is better than hemodialysis.
Okay, thank you so much, Professor Hani, for this very comprehensive lecture and responding to all our questions, and this very fruitful discussion by all attending professors, Professor Ayman Rifai, Professor Hisham Sayed, and thank you for all attendees for their interaction and enriching this session with their questions. And no more questions, no more comments, and excuse me to close. I think we came to the end. Thank you so much.
Thank you very much.
Thank you for all attendees. Thank you, Dr. Mu'tasim, for being the coordinator for this session. The coming session is coming Wednesday, waiting 9:30 p.m. Cairo time, will be with Professor Wissam Ismaili speak about systemic lupus and clarifying most of the stages of lupus pathologically and clinically pathological form. Waiting for you all and waiting for such interesting and fruitful session again. Thank you so much. Excuse me to close. تصبحوا على خير والسلام عليكم ورحمة الله.
وعليكم السلام ورحمة الله وبركاته.
شكرا جزيلا. مع السلامة.